All right, welcome back, everyone. We are still in dermatology. We're doing session 2 right now after 5 minutes break. We're going to do 25 minutes of studying and then another 5 minutes of break. Let's hope that we can finish a lot more than we have finished in the previous video. What we finished with was the Stevens-Johnson syndrome on page 293. Now we are going to stop and start with the toxic epidermal necrolysis. So TEN is the most serious version of the cutaneous hypersensitivity reaction. It's a reminder that we said before that Stevens-Johnson syndrome and toxic epidermal necrolysis are kind of like the same disease, but in a different severity. The severe part, or the severe disease, of the toxic epidermal necrolysis. Much more of the body surface area it's involved. It's up to 30 to even 100%. We said it's less than 10 to 15% in the Stevens-Johnson syndrome. Mortality may be as high as 40 to 50% in comparison, less than 5 to 10% in the Stevens-Johnson syndrome. Well, we also said before in bullous pemphigoid that there is a sign called the Nikolsky sign and is present as well in the toxic epidermal necrolysis. And the sign itself is that the skin easily sloughs off. And the TEN, it has a similar features to the staph is called it skin syndrome. However, in the toxic epidermal necrolysis, it is drug-induced as opposed to being caused by a toxin coming from an organism. In the staph scalded skin syndrome. Sepsis is the most common cause of death, but prophylactic systemic antibiotics are not indicated. So that's kind of weird, but we should really remember that. So we should understand that sepsis is the most common cause of death, but we do not use prophylactic systemic antibiotics in this case, which is kind of weird. I still don't know why. All right. So how are we going to diagnose that? Diagnosis is with a skin biopsy. Systemic steroids are not as effective treatment and may in fact decrease the chance of survival because it decreases, I think, because it decreases the immunity as well. We said also steroids have no proven benefit in Stevens-Johnson syndrome, so we should really associate those two with each other. All right. Again, we have here what is called the fixed drug reaction. So that's an disease here. This is a localized allergic drug reaction. Again, localized. That's a little different. Localized. It's not systemic. That occurs at precisely the same anatomic site on the skin with repeated exposure to the drug. Fixed drug reactions are generally round, sharply demarcated lesions that leave a hyperpigmented spot at the site after they resolve. So again, it's a fixed drug reaction, so it's the same repeated reaction that can happen on the same exact anatomic site of the skin. It happens with repeated drug exposure. So we should remember that. And it's a sharply demarcated lesions that leave a hyperpigmented spot at the site after it resolves. The fixed drug reaction can be treated with the steroids, but here it is topical steroids, which makes sense. All right, now we have erythema nodosum, very important one. This condition, it presents as a painful red raised nodules, painful. Remember what was painful before? It was bullous pemphigoid or pemphigus vulgaris. It was pemphigus vulgaris. It was painful but not periuretic. Okay, all right. So again, the erythema nodosum here is painful red raised nodules. They appear on the anterior surface of the lower extremities. Anterior surface of the lower extremities, so kind of like the shin of the tibia or something like that. Nodules are tender to palpation. Again, they are painful. Nodules do not ulcerate, so we cannot expect any ulcers there. And nodules last about 6 weeks. Okay? All right. Erythema nodosum is secondary to recent infections or inflammatory conditions. Uh, what is it like? It's like the following. Either it can be with pregnancy, it can be with recent staphylococcus infection, pseudomycosis, histoplasmosis, sarcoidosis, inflammatory bowel disease, syphilis, hepatitis, and enteric infections such as Yersinia. It's kind of a long list here, but basically it can happen with infections or inflammatory conditions, and along with that, pregnancy. How do we treat it? We treat it with analgesics because again it is painful, and with non-steroidals, and by treating the underlying disease. So those are the two things we do: underlying disease, analgesics, and non-steroidals. Okay. So we are now officially done with the bullets and with the hypersensitivity actions and drug eruptions and so on. And we're gonna start right now with the infections. Okay. Infections, we're gonna start with fungal infections. The first we're going to talk about is the tinea. We have different ones. We have tinea pedis, which is on the, I think the foot, and tinea curaris, tinea corporis, the tinea versicolor, tinea capitis, and onychomycosis, which is just the tinea or a fungal infection in a different part of the body. What is the diagnostic test? So the best initial test is the potassium hydroxide test of the skin. The leading edge of the lesion on the skin or nails is scraped off with a scalpel to remove some of the epidermal cells and some of the nail or hair. The KOH, or the potassium hydroxide, has the ability to dissolve the epithelial cells and collagen of the nail, but not the fungus, so we can see the fungus under the microscope. But the most accurate test is the culture. It's kind of hard, it's going to take time, so that's why it's not the best initial test, but it is the most accurate. Molds that grow on the skin, like dermatophytes, they take up to 6 weeks to grow, so it takes a long time, even on a specialized fungal medium. A specific species usually does not need to be isolated in most cases, unless the infection is of the hair or nails. Okay? All right. So what is the treatment here? For onychomycosis, or the nail infection, or the hair infection like tinea capitis, the medications with the greatest efficacy are the oral terbinafine or itraconazole. So again, oral terbinafine or the itraconazole. I'm not sure if I'm spelling those right, but you can read them. These medications are used for 6 weeks for fingernails and 12 weeks for toenails. I remember when I was in college, they said that you have to treat fungal infection for such a long time. You can't really treat it for just a couple of days. And the reason why is that they are embedded in the cells themselves, and you need a long time for the cells that contain or have the infection to slough off or just die and be replaced with the new ones. And you are giving the treatment specifically to prevent further disease and further cells to be infected. I'm not really sure if this is 100% accurate here, but I remember that, and it might help other people to remember this part. 6 weeks and 12 weeks for toenails. Terbinafine is potentially hepatotoxic. I think it's really important in step 2 CK that we remember the side effects. It's really important because sometimes this is how we choose the medication. So it's hepatotoxic, and it is important to check liver function tests periodically. Griseofulvin, which is another oral medication, it must be used for 6 to 12 months, which is a long time and has much less antifungal efficacy than terbinafine. So we don't really use griseofulvin as much as we use the other one, terbinafine. All of the other fungal infections of this of the skin that don't involve the hair or the nails, like we talked before, may be treated with any of the following medications, like ketoconazole, clotrimazole, iconazole, anything that has a zole at the end would work. So it doesn't really matter when it comes to any other part of the skin other than the hair and the nails, special parts. Okay. It says here that there is no clear inefficacy or adverse effects among them, or the medications that we talked about, when they are used topically. So systemically it's different, but topical they are not different. When they use systemically, ketoconazole has the following adverse effects. It's hepatotoxic again, and it causes gynecomastia. This is why ketoconazole is not a good choice for onychomycosis. There is no topical form of fluconazole. Fluconazole has less efficacy for dermatophytes of the nails when they are used systemically. So we can't really choose. Fluconazole is a topical medication, and remember that ketoconazole is not a good choice for onychomycosis. It's going to be used for a long time. It has hepatotoxicity and gynecomastia. Okay? Alright, so we're done now with the fungal infections. Now let's talk about bacterial infections, which is a very important and a kind of long part here. Okay, bacterial infections, these include the following: impetigo, erysipelas, cellulitis, folliculitis, Funkals, carbuncles, and necrotizing fasciitis, and paronychia. Okay, let's start with the treatment. In bacterial skin infections, in general, like impetigo, erysipelas, cellulitis, folliculitis, Funkals, and carbuncles, are treated as the following. First, dicloxacin and cephalexin or cefadroxil, which are the first generation cephalosporin, I think, and penicillin derivatives. The IV equivalent of dicloxacillin is oxacillin or nafcillin. The IV equivalent of cefadroxil is cefazolin. So we can use the IV forms or we can use the oral forms. If a patient is allergic to penicillin, which can be a case, but the reaction is only rash, then cephalosporins can be safely used. This is actually just in general. It's not only for the skin infections. This is far less than 1%. There is far less than 1% cross reaction between penicillins and cephalosporins. The cross reactivity is actually estimated to be 0.1%. If the penicillin reaction is anaphylaxis, well, we can't really risk it. Cephalosporin cannot be used. The alternative antibiotics that can treat the skins are the macrolides, such as erythromycin, and clarithromycin, or the newer fluoroquinolones, like the levofloxacin or moxifloxacin or something like that. Ciprofloxacin will not adequately cover the skin, so we don't use Cipro. It's a popular choice, but we do not use it in this disease specifically. So we use levofloxacin, gatifloxacin, or moxifloxacin. Also, vancomycin is only for IV use for skin infections. So only for IV use, vancomycin. Oral vancomycin is not absorbed and is usually only for Clostridium difficile infections. So, very important to note, it's not for systemic use. We considered the use of IV vancomycin when? We actually use it when we suspect a MRSA infection, methicillin-resistant Staph aureus, such as in the nursing home patient or in a patient who has been in the hospital for a long time. The oral alternative would be linezolide or Bactrim. The linezolide is more famous here, or at least for me. So we don't really use the commercial names here. Linezolide. All right. That's just the general idea about the treatment. Again, for a quick review here, we said that initially we use dicloxacillin, cephalexin, or cefadroxil. We can use oxacillin, nafcillin if we want to use an IV form instead of dicloxacillin. We can use cefazolin instead of cefadroxil if we want, again, the IV route. If the patient is allergic to penicillin, but it's just a rash, we can still use the cephalosporin. If the patient is having anaphylaxis with the penicillin, we should change it. We should not use cephalosporins. We can use macrolides like erythromycin or clarithromycin. We can also use fluoroquinolones like levofloxacillin or moxifloxacillin, but we should not use ciprofloxacillin because it does not cover the skin adequately. Also, we can use the vancomycin, but we cannot use an oral form. We should use the IV form only, and we can consider it if we think that the infection is caused by MRSA, like in a nursing home or in a hospital for such a long time. And finally, the alternative for vancomycin, if we want to use the oral form, is linezolide. All right, now let's talk about the different types of bacterial infections. We can specifically in each one. First is going to be the impetigo, or I hope that I'm pronouncing this right. This is a superficial bacterial infection of the skin. It's limited largely to the epidermis, so again, it's a superficial infection, not spreading below the dermal epidermal junction. The infection is described as weeping, oozing, honey-colored, and draining. It occurs more often in warm, humid conditions, particularly when there is a poverty and a crowding of children. So that's a good environment for infections in general. It is both contagious and auto-inoculable. The impetigo, it can cause glomerulonephritis, but it does not cause rheumatic fever. That's a good part to remember here. So it can cause post-coccal glomerulonephritis, but not rheumatic fever. Again here, impetigo is more often caused by staph, but is sometimes caused by Streptococcus pyogenes, also known as group A strep. So usually staph, but sometimes strep pyogenes, which is group A. Impetigo is treated by applying topical antibiotics such as mupirocin. If topical antibiotics are not effective, then anti-staph oral antibiotics can be used. So topical mupirocin. Okay, now we're done with impetigo. The erysipelas. Erysipelas involves both the dermis and epidermis. So this is the first difference. Impetigo, that's superficial bacterial. It does not really pass the dermal epidermal junction, but here it is both dermis and epidermis, and is most commonly caused by group A strep. Another different part here. It's usually Erysipelas. Here is a group A strep. The impetigo, it's staph, but sometimes the group A strep. Erysipelas is more likely than other bacterial infections to result in fever and chills and bacteremia. It also can cause bright red, angry, swollen appearance of the face than any other type of bacterial infections that we have talked about or going to talk about. The treatment here is going to be to use the systemic oral or IV antibiotics previously described in the first part. If the culture confirmation of the organism as Streptococcus, then penicillin G or ampicillin can be used. In general, if we have a culture of any organism, we should use the specific antibiotic for this organism. If we have sensitivity, that would be better. All right. Okay, so now cellulitis. Cellulitis, this is a bacterial infection of the derms and the subcutaneous tissue. So we're going deeper here with the staph and strep. Cellulitis is treated with the antibiotics previously described and based on the severity of the disease. If there is fever, hypotension, and signs of sepsis, or if there is oral or the oral therapy has not been effective, then the patient should receive IV antibiotics here. Oxacillin, nafcillin, or cefazolin is the best therapy, like we talked before, and Treatment is generally empiric because injecting and aspirating sterile saline for a specific microbial diagnosis has only a 20% sensitivity. So we don't really use here the culture part. Okay. After cellulitis, we're going to talk about three diseases altogether: the folliculitis, Fungal, and carbuncles. These three disorders, they represent three different degrees of severity of the Staphylococcus infection occurring around the hair follicle. Occasionally, folliculitis, it can occur from Pseudomonas. That's just occasionally, but usually it's staph. And those who contract it in whirlpool or hot tubs. So, a person, hot tub, swimming pool, or whatever, and he's having folliculitis, we should think about Pseudomonas more. As folliculitis worsens from a simple infection superficially around the hair follicle, it proceeds to become a small collection of infected material, and that's going to be the fruncle. When several fruncles become confluent into a single lesion, it becomes known as carbuncle. So that's how it progresses. Essentially, a localized skin abscess, that's the carbuncle, that must be drained. Folliculitis is rarely tender, while fruncles and carbuncles are often extremely tender. How are we going to treat it? Well, folliculitis can be treated with a topical mupirocin, just like we talked about impetigo. But fruncles and carbuncles need to be treated with a systemic anti-staph antibiotics, such as dicloxacillin and cefadroxil. All right. Now let's talk about a really important part here, or a really important disease, which is necrotizing fasciitis. Necrotizing fasciitis is an extremely severe and life-threatening infection of the skin. It starts as a cellulitis that dissects into the fascial planes of the skin. Streptococcus and Clostridia are the most common organisms involved because they produce a toxin that worsens the damage of the fascia. Diabetes increases the risk of the development of fasciitis, which is understandable, decreased immunity. And how is it going to present here? In necrotizing fasciitis, it presents with very high fever. It has a portal of entry into the skin, so we can have like I don't know, some sort of a cut or something like that, I think. Pain out of proportion to the superficial appearance. We can have bully, we can have palpable crepitus. I think that's more related to Clostridia. Okay, and well, how are we going to diagnose such a thing? Well, the following tests can be used. We can have an elevated CPK. It's not really specific, but I think can be elevated. We can perform X-ray, CT scan, and MRIs that show air in the tissue or necrosis. All of these laboratory methods of establishing a diagnosis lack both sensitivity and specificity. Surgical debridement is both the best way to confirm the diagnosis as well as the mainstay of therapy. There is a side note here that says if presented, which is the necrotizing fasciitis, if it is presented with an obvious clinical case with crepitus, pain, high fever, and a portal of entry, answer surgery, not a test such as X-ray, as the best initial step. So here, just treat the patient right away if you are clinically sure that this is necrotizing fasciitis. How are we going to treat it? Well, treat with a beta-lactam or beta-lactamase combination, kind of like ampicillin, sulbactam, ticarcillin, clovinolate, clovinic acid, and piperacillin, tazobactam. We use any of these. If there is a definite diagnosis of a strep A, group A strep, then the treatment is with clindamycin and penicillin. So this is specific here. So usually we use a beta-lactamase combination. Otherwise, if the diagnosis is definite and we know that it is group A streptococcus, Then we should treat it with clindamycin and penicillin. Clindamycin and penicillin. All right. Without adequate therapy, necrotizing fasciitis has an 80% mortality. Very serious disease here. All right, we're almost done with the 25 minutes, but I think we can extend it for another 2 or 3 minutes so we can finish the rest of the infection. We have viral infections here, and then we can stop and start the next session with the sexual transmitted disease. All right, so we can just finish that part. All right. So before we go to the viral infections here, we have a paronychia that we haven't talked about. This is an infection that is located under the skin surrounding the nail. It's generally just treated with a small incision to allow drainage and with some anti-staph antibiotics, as previously we described before. So it's very easy actually to diagnose and treat. Now let's talk about the viral infections. We have the herpes simplex. Herpes simplex infection of the genitals are characterized by multiple painful vesicles. Very easy to distinguish. They are usually obvious by examination, and you should proceed directly to the therapy with a cyclovir, famciclovir, valacyclovir. How we're going to diagnose it? The best initial test in the event that the diagnosis is not really clear, all the lesions have become confluent into an ulcer. The best initial test is a Zank smear. And the Zank smear is somewhat non-specific in that it will only determine that the infection is in the herpes virus family. They can't really say it's simplex. Zank smears detect multinucleated giant cells and are similar in technique to the Pap smear. A scraping of the lesion is immediately placed on a slide and sprayed with the fixative. Kind of easy. Most accurate test is the viral culture, of course. It just takes 24 to 48 hours. But usually we treat it right away. It's really not that hard. The most common wrong answer when it comes to viral infections is serology. Serology is not a useful test for diagnosing acute herpes infection because it's just everybody has herpes at one point or another, especially herpes simplex, and it's going to be positive, so it just doesn't make sense. How are we going to treat it? Oral cyclovir, like we said, or vanciclovir, or valacyclovir. The topical acyclovir, it's extremely little efficacy, and it should be noted that the treatment here is not aimed at eradicating the disease. We can't really eradicate herpes; it just goes back into the ganglia. But the treatment is aimed at rapid progression into recovery and at decreasing the symptoms. So that's it. Topical acyclovir, as I said, doesn't have really that much of an efficacy. The topical penciclovir has some utility for oral herpetic lesions, but it must be used every 2 hours. It just doesn't really work. The treatment of acyclovir resistant herpes is with foscarnet. Okay. So we're done with the herpes simplex, really easy. Now let's talk about herpes zoster or varicella. The chickenpox is primarily a disease of the children. It is generally not treated with antivirals. If the child is immunocompromised or the primary infection occurs in an adult, then that's a problem. We should use antivirals like acyclovir, famciclovir, and valacyclovir. The complications that can occur with the varicella virus are either pneumonia, hepatitis, or dissemination. The outbreak of shingles, also known as dermatomal herpes zoster. I think in some cultures, like here in Egypt, we call it the firing belt because it kind of looks like a belt and it really hurts, kind of like fire. It occurs more frequently in the elderly and those with defects of the lymphocytic portion of the immune system, such as people who have leukemia, for example, lymphoma, maybe HIV as well, or those who are on steroids. So people who are immunocompromised, especially when it comes to the lymphocytic system. So that's when we expect the outbreak of shingles to occur. There are vesicles that are 2 to 3 millimeter in size at the stages of development or on an erythematous base. How are we going to diagnosis? Although the dengue prep and viral culture are the best initial and most accurate, like we said before, they are generally not really necessary because little else will produce a band of vesicles in a dermatoma distribution besides herpes zoster. So we can just treat it right away. How are we going to treat it? Well, steroids use is still not clearly beneficial. We can't really use steroids. Although the best evidence for its efficacy is in the elderly patient with severe pain. So don't use steroids in general, just use it when there is an elderly patient, severe pain. Second, the rapid administration of acyclovir still has the best efficacy for decreasing the risk of post-herpetic neuralgia, which is a really nasty, painful thing to occur to a patient after the herpetic lesions have subsided. Other treatments that we can use is gabapentin, which is the most effective analgesia for the post-herpetic neuralgia. So if it happens, we can use that. Tricyclic antidepressants and topical capsaicin. Finally, the non-immune adults exposed to chickenpox should receive varicella zoster immunoglobulin within 96 hours of the exposure for it to be effective. That's a really important part here. So again, I'm gonna repeat that, is that the non-immune adults, so the adults who have not been immune before, who are exposed to chickenpox, they should receive varicella zoster immunoglobulins within the 96 hours or 4 days of the exposure for it to be effective. Okay, so now we're done with the viral infections and all the infections in general, we're going to talk next about the sexually transmitted disease, but we should take 10 minutes of break because we have extended our study session to more than 25 minutes. All right, 10 minutes and I'll see you again. Bye-bye.